Hello. Hello, Liz. How you doing?
Good, good. How are you?
I am good. I'm good. How are you feeling about today?
I'm excited. I'm really excited, you guys. So today we are going to be talking about medication and OCD. So Dr. Pascar has joined us, and we are so excited to have you with us. I will tell you that we get so many questions around meds, and Chris and I always just say, well, we're not psychiatrists. We can't answer that. And so everyone's going to be so excited to have you here and have the ability for their questions to get answered. Thank you so much for joining us.
Thank you so much for having me. It's a topic I speak on a lot, and there are a lot of misnomers, and people have a lot of questions. So hopefully we can help people out today.
Yes, we'll clear a lot of things up and hopefully give some insight in different ways. Couple of updates. As always, please remember that these talks are intended to be educational and supportive. We're not going to be able to give any specific medication advice or specific treatment advice, and we really want you to keep that in mind, and we want you to save that for your individual therapist or your individual psychiatrist. As always, please remember that IOCDF and our live streams are not intended to replace a crisis line. So if you're feeling unsafe or suicidal, please call 911 or 988, and of course you can also go to your local emergency room. We are so excited. There's so many amazing things coming up. I look down and I'm like, oh my gosh, it's already January 18th. It felt like it was New Year's yesterday. So time is flying, and there's so many important but also awesome and exciting topics that we're covering over 2023. So please go to iocdf.org/peace of mind. And there you can see all of our upcoming live streams, talks, events. It's where you can also submit content and things that you want to be addressed. So I don't want to take up any more time, because I know, Chris, we've got like a million pre-submitted questions. We have a lot of questions, and so we are just going to hop in. But before we do, Dr. Pascar, do you want to go ahead and share just kind of your background in OCD, why you entered the field, and what you do and where you're at?
Sure. So my name is Steve Pascar. I am a psychiatrist in New York City, and I run a practice called OCD NYC, where we really specialize in OCD and related disorders like body dysmorphic disorder, hoarding, skin picking, hair pulling, hypochondriasis. And I've been doing this for over a decade. And I first got involved and interested in OCD even prior to going to med school. I actually have a couple of family members that had OCD, and I actually started out being originally interested in the therapy. And then I ended up deciding to go to medical school. And now my practice is interesting because I do both. I'm one of the few people that probably 50% of the people, I do just their medicine. And usually refractory cases usually come to me, people that have seen several psychiatrists, maybe that don't have so much expertise in OCD, and are finally referred to me. But I also do a ton of therapy, which, to me, one of the things I always tell patients is one of the biggest things about medicine that it does is often kind of lower symptoms of OCD down to a level where they can finally really approach the therapy, because nobody gets better from OCD without therapy. There, as much as people would hope it would be so, that we could give people medicine for OCD and it would cure them, that's unfortunately not something that happens. And so, I choose, because I really want to treat the whole disease, to do both medicine and therapy as well.
Thank you for saying that. You kind of brought up two questions in your talk. The first is, can you talk a little bit about the importance of somebody working with a prescriber, a psychiatrist that really understands OCD? Because I think obviously it's already difficult to find on our end the treatment, find a specialist in OCD, but how important is it? And what do you notice that you're able to sort of pick up on as somebody that focuses on OCD related disorders? And then the second part to my question is, talk a little bit about the importance of expand on the need for treatment, because I think a lot of psychiatrists don't have the same philosophy as you. And Liz and I will see clients that come to us after being meds on 5 or 6, 7 years, and they're like, we never were told that there was any kind of behavioral therapy for this.
Yeah, and so I think it's really important. I think often, like anything, I think if you see a generalist, and generalists are great, right? That we need people that can see a wide breadth of disorders, but OCD is a little tricky. And I think that when you don't treat a lot of OCD, there are some very common mistakes that get made. And one of them is, we use kind of the main treatment for OCD is called SSRIs, which are selective serotonin reuptake. And those are also the most common, medicines that we use for depression and all of the anxiety disorders. The difference is with OCD, we require higher dosages. So one thing that you see a lot when people see a generalist is they've been tried on several SSRIs, but they're not real full trials because they've never been on high enough doses that we would even expect them to get a response. So a lot of people will come to me and say, I've already been on Prozac and Zoloft. But then when I ask them what the doses are, they've never actually been high enough. And so, that's one of the key things that we catch a lot of with OCD. And then, there's also kind of issues picking up a lot of the correlated disorders. When you do enough OCD, you know to ask questions about body dysmorphic disorder, trichotillomania, skin picking, as well as hoarding. And so a lot of the times I'll see people that have been diagnosed with OCD, but they've never even been asked about those things. And so those never even get picked up because somebody doesn't do enough OCD to know when someone's got OCD, you have to kind of check a bunch of other disorders that tend to travel with it very often. And so those are just a couple of the other reasons it's really important. And I think, the other thing is, and I think this is a psychiatrist's hopeful responsibility, there's, unfortunately, as you both know, it's been very kind of bifurcated in that, psychiatrists have just become these guys that do medicine, and then they leave the therapy to psychologists and mental health counselors and social workers. And it's really incumbent on everybody to know what are all the evidence-based treatments for each disorder. And so every psychiatrist should know that for OCD, there are two main evidence-based treatments. Exposure and response prevention is the therapy, and high-dose SSRIs is the main treatment. And unfortunately, like you said, all too many people, they see a psychiatrist and they just give them medicine, and they don't even know to avail themselves the kind of exposure and response prevention. And again, nobody gets better from OCD with medicine alone. I've never seen it. I've been doing this for a long time, and I'm pretty good at it. And I can say, I think there was one person, and I didn't really even buy it. But other than that, again, usually we can lower symptoms with SSRIs, sometimes by 40, 50%. But that still leaves a lot of OCD. And if they keep doing all their compulsions and never learn exposure response prevention, it never gets better because they're just reinforcing it. And no matter what I do with medicine, it's not going to change.
So can we talk a little bit about the average doses that would be considered a therapeutic dose of SSRIs for OCD? And so for everyone listening, I want you to listen to this because it'll be really important if you are like, medication's not helping me or my OCD, and you realize you're on a lower dose than what would be a therapeutic dose for OCD, because we'd want you to go talk to your psychiatrist. You should never make changes on your own, but we want you to go talk to your psychiatrist. The second thing is, can you also talk about when we can, how long and what does it look like for someone to be on a therapeutic dose before they should expect the benefit or the full change, right? Because sometimes people are like, I started my meds yesterday, I don't feel anything. And we're like, well, we wouldn't really expect you to yet. So what would be kind of the average highest doses? And then when should people expect to see a difference?
Sure. So great question. So, a couple of things. So typically, with these drugs, there are kind of the standard lowest dose that's used to treat things like depression and anxiety, and then the OCD doses. So, the SSRIs are drugs including Prozac, Paxil, Zoloft, Luvox, Celexa, and Lexapro. And so, with Prozac, the lowest starting dose for depression is 20 milligrams. And often 20 to 40 milligrams will work for depression or for anxiety. For OCD, typically it's going to be between 60 and 100 milligrams. And, usually what I do is I try to get people up to 60, and you don't want to go too quickly or people can get side effects. I like to get them up to 60, and I like to wait at least a month. If 60 is going to be a dose that works for them, I should see something in a month, not everything. We actually know that if a dose works for somebody, they can keep getting better and better over a course of 3, 4, 5, 6 months. But if after a month at 60, I don't see anything, I assume that's not the dose for them, and I'll usually increase it. And typically, again, people with OCD for Prozac, it'll be between 60 and 100 milligrams. For Paxil, the same, 60 to 100 milligrams. And for Celexa is the same, about 60 to 100 milligrams. With Zoloft, usually between 200 and 300 milligrams. And with drugs like Luvox, similarly, usually 200 to 300 milligrams, and Lexapro anywhere from about 30 to 50 milligrams. And again, usually you need at least a month to see something. Any less than that, I wouldn't expect very much. But usually after a month, I like to see something at a dose. And usually if I see something, so if I get someone to 60 milligrams of Prozac, let's say, and in a month I see they're improving, but they're still very symptomatic, one of the mistakes people make is after a month, someone's a little improved on 60, so they'll bump them up to 80, and a month later they're even better. But are they better because you bumped them up to 80, or were they kind of headed there anyway? And so usually if someone's improving, I give them a month. And then I check another month. And if they keep improving, I keep my hands off of it. And I see how much they improve. If they eventually get to a month where nothing happens, they don't improve anymore, after a month, that kind of tells me they're probably not going to improve much more than that. And then I make a decision of whether to go up on the dose or not. And the only other thing I would mention is sometimes we use even higher doses than the doses I'm talking about. And one of the things I always try to explain to people is, if I give somebody 60 milligrams of Prozac, the only thing I know for certain is at some point in time, they have 60 milligrams in their mouth. That's all I can ever be sure of. I don't know how they metabolize it, so I don't know how much gets into their blood. And I don't even if I knew that doesn't tell me that much, because I really care how much crosses what's called your blood-brain barrier and gets into your brain. So there are going to be people, just like we know most things have a bell curve, that while the average man is somewhere between 5'6" and 6'2", there are men that are 7'1", and there are men that are 4'6". And so we know the standard doses, let's say 60 to 100 of Prozac, but there are going to be people that rapidly metabolize it and break it down quickly. And so I have people on 120 milligrams of Prozac, and occasionally there will be people on really low doses because they break it down slowly. So we kind of know these are estimates, but there's never, sometimes people say, well, this is the top FDA approved dose, right? That really means that it's kind of a dose that's been studied for, and usually not even for OCD. And so really what we're looking for is increasing medicine until either we get a benefit or we start to get side effects. And the most common thing with SSRIs when the dose gets too high is people just start to feel tired. They just kind of feel drugged. And I know a lot of people with OCD, because they do a lot of reading, worry about serotonin syndrome. This is not a thing that typically happens on single drug therapy, even at high doses. It's not a common occurrence to happen on SSRIs alone. Things like serotonin syndrome typically happen when you mix SSRIs with other more complicated drugs like MAOI inhibitors. But it is a reason that a lot of generalists, as we talked about before, they're a little nervous. Part of why they don't go up higher is because they're not used to using higher doses. And that's okay. But then they need to know to start to refer to somebody that does this. And I think, as you guys know, it's the same thing in therapy, right? That there are generalists and they can work with some OCD cases, but it's important. There's nothing wrong with saying, you know what, this is a little bit above what I'm used to. And I'm going to refer to a therapist that does a lot of OCD, or a psychiatrist that does a lot of OCD, just like any one of us. If we saw something that we don't see a lot of, hopefully we'd be responsible enough to say, hey, this is schizophrenia. I don't do a ton of that. Let me help you get to somebody that does.
That's right. That's our ethical hopefully goal of every clinician.
You said something, you kind of read my mind, is one of the things that it always is complicated for us when we recommend somebody to see a psychiatrist to get a med eval. Our clients, and I'll be the first to admit it myself as well, when I'm on medication, we read, we internet search, etc. how do you work with clients if they've done a lot of research and they come in and they're very afraid of, let's say, side effects, or they've read certain things, or I would say even the stigma that a lot of people feel going on medication? Like, how, as clinicians, can we maybe talk to, because we get a lot of clinicians that watch our live as well and watch them back, how as clinicians can we talk to our clients and kind of, still have them encouraged to go see a psychiatrist with some of those fears? And then what are some things in the room that you do to make people kind of feel a little bit more comfortable in taking medication?
Sure. So I think I'm going to maybe answer that question in backwards order, if that's okay.
Whatever works, yeah.
So I think, there's stigma that people have around medicine, and there's a bunch of things. And I think it's always important for both the therapist and the psychiatrist to figure out why. What is it about, and be able to have a discussion about, tell me what it is about medicine that either scares you or a reason you don't want to take it. And, there are some common kind of things that we hear, right? Some of the most common are, I heard that if I go on SSRI, it's going to change my personality. I'm not going to be me anymore. And that usually is a pretty unfounded fear. There are cases sometimes when SSRI doses get high for a very small group of people. They maybe find that they don't feel the same amount of highs or lows, which in some ways is good. But unfortunately, some people get things where they'll say, I'm on SSRI and I can't cry. And I kind of like to cry every now and then. There's stuff we can do about that. And usually it's about adding an additional drug that affects norepinephrine and dopamine. And so even when that happens on those rare occasions, there are things that can be done about it. I think also, as you guys know, especially with a lot of OCD patients, some of them actually think I shouldn't be on medicine because I'm cheating. I want to do the therapy, and I should be able to do this on therapy alone. And they almost feel like it's the cheater's way out. And one of the things, I often tell them is, again, this is a medical disorder. And just like anything else, if you had diabetes, you'd be on medicine. If and this is a medical disorder. This is a brain disease. And I often will maybe explain to them a little bit about what goes on in the brain of somebody that has OCD. And that, look, therapy often, for many cases, therapy alone works. And if somebody really wants to do that, I'm fine with it. And I usually say, but let's give it a trial of therapy alone for a while. And then let's say we're going to revisit this in a month or 2 months and see, are you making progress? If you are, fantastic. But if you're hitting sticking points, and often that's just because you're too anxious, or you're just unwilling to kind of, the OCD is so loud that we need to kind of bring down the volume a little bit. And so, I think those are some of the reasons. Either they're worried it's going to change their personality, or that it's cheating in some way. And then I think there are a lot of kind of fears, about medicine in general. Is it going to damage my brain? What do we know about these things long term? And the data that we have, really doesn't support that there are really any long-term problems. Prozac has been around now since the late 70s, early 80s. So we're talking about drugs that have been around that we've gotten to see 40 years of. And so it doesn't appear to us that there are really, some people worry, well, is this going to damage my liver? Is it going to hurt my kidneys? And one of the things I always remind them when they ask those questions is, because I don't want them to think, well, he just gives this medicine. Of course, he's going to say they're all perfectly safe. But I tell them, look, for bipolar disorder, we often have to use lithium. And we have to be careful because lithium can affect the kidneys. And, we have to use medicine sometimes like atypical antipsychotics, and those can cause kind of movement disorder symptoms. It's just not the case with SSRIs. They are a fairly safe medicine that we don't really even have to monitor with labs. So I think it's, one of the things I always tell people is, I'm okay if somebody doesn't want to be on medicine. But if they're not going to be on medicine, I don't want them to be on it for reasons that aren't true. And again, as you mentioned, right, people go on the internet, and this is everybody, but especially for people with OCD, they tend to research a lot. And the internet, as we all know, is not necessarily the best place for information. And one of the experiments I do with my patients is I tell them, I say, can you name any drug you've ever heard of? And they'll name something. And then I'll say, name any side effect you can think of, no matter how weird. and then I'll punch the two in together to Google, and we'll get 1,000 hits no matter what we choose, right? Because and so it's just realizing that the internet's not a great place for a lot of information, and part of that is them kind of trusting me that, look, this is what I do, and I always tell people, one of the things I always tell them, to give them a sense of security is I would never do anything with you that I wouldn't be doing if you were my family member. This is what I would be doing, this is what I would recommend for my brother, my sister, my father, my mother, and it's really also, letting them know, one of the things I mentioned earlier is about people worrying it changes their personality. And one of the things I tell people is it actually usually allows your personality to come out, because your personality has been so kind of covered over with anxiety and your OCD that it kind of doesn't allow you to be you at your fullest. And so we can kind of get those things improved. You actually start to become more you again. And so those are just some of the things we try to do. But I think it's a constant thing. And again, with going on the internet and really talking to them about how OCD works and how that usually becomes a compulsion. And so it's also really educating on why it's not good just from an informational standpoint, but also why it's not good to look certain things up from an OCD treatment standpoint, from a compulsion standpoint. So really trying to educate them on both.
Totally. I think there's so many nuances, and this is why we really want you working with an OCD specialist. And we're so grateful for your time, because it's clear that, yes, you're a psychiatrist, but you specialize in OCD and you know the ins and outs. And I want people to hear from you, because I think it's so important for them to also set what their expectations and standards should be for their own psychiatrist, right? Versus getting medication from a PCP or somebody who doesn't understand OCD. So we're going to hop into questions because lots were posted, but thank you so much for sharing some of the basics. And I have some other questions specifically around medication and OCD treatment and ways that we might augment treatment, and in addition to SSRI. So Chris, do you think we should save those more for the end and hop into questions first, or what do you think makes sense?
Yeah, we could do that.
Okay, so the first question, Amanda, hi Amanda, who's on the back end for my OCD app. The first question at 12:12 is, what if a psychiatrist won't allow 30 to 50 milligrams for Lexapro due to elevated liver enzymes? What would be a better choice of an SSRI?
So elevated liver enzymes is not common. It can happen though with any SSRI. So there's nothing peculiar or particular to Lexapro. And with SSRIs in any group of medicines, in the same way that, one of the things maybe we didn't discuss a little earlier is there's no evidence that any SSRI is better than any other SSRI for OCD or for anything for that matter. At the same time, there are some people who respond to Zoloft and not Prozac, because it's Alexa but not Lexapro. We don't really know why. And in the same way, people can get, fairly rare side effects to one and not another. So usually if somebody gets elevated liver enzymes, the first thing you want to do is stop the medicine and then keep repeating enzymes until they're normal again. And then I think you can do a trial on a different SSRI. If it were me, the only one in that particular case I'd probably avoid is trying Celexa, just because Lexapro and Celexa are so chemically similar that if they got elevated liver enzymes on one, I probably might not try something so similar. But other than that, I think you try another SSRI and you check liver enzymes. And liver enzyme elevations can kind of happen with just about any medicine. Really, liver enzyme elevations aren't problematic until they're usually 3 to 4 times normal. And so mild elevations, often sometimes we'll even send them to their primary care doctor, and they'll say, look, we'll monitor them. They're slightly elevated, not dangerous. But it's, again, I think the second you see anything like elevated liver enzymes, you want to address it with a doctor. You also want to make sure it's because of the drug, right? Some people, they're on a medicine and they see their generalist, they get blood work and they see elevated liver enzymes. And I think sometimes there's just an assumption, oh, well, it must be this. Well, when's the last time you had your liver enzymes checked? This could have been going on for 6 months, even before the medicine. So trying to figure out, first, is it the medicine? Let's make sure that it is. And then, often I think stopping it, seeing if they go down again, and then usually a trial on a different SSRI, and then if you continue to see elevated liver enzymes, then it's really discussing with the person's primary care doctor, or if the primary wants them to see a hepatologist, somebody who specializes in the liver, and then a discussion of risk versus reward. Because sometimes the answer will be, you know what, SSRIs really help this person's OCD, and there are very mild liver enzyme increases. The liver doctor might say, I think it's worth it. I think, and we'll just keep following the enzymes. But I think, it's something to be aware of. But again, not a common side effect. And with other drugs like Depakote, which we use for bipolar disorder, we actually have to follow liver enzymes regularly because it's something that can happen. We don't follow liver enzymes regularly with patients on SSRIs because it's such a rare occurrence. And so it's not really something that's very common, but it can happen with any medicine.
Great feedback. Next question at 1212 is, hi, I've suffered from OCD and GAD for more than 20 years and I've been on SSRIs. Is there a possibility that the SSRIs disrupt the sleep architecture in the long run and trigger a vicious cycle of poor sleep?
So I guess first, before we say anything, we should discuss what sleep architecture means, because I'm not sure if everybody's going to know that. So sleep architecture really is we all have a sleep cycle, and it usually takes about 90 minutes to get through a sleep cycle. And we start with light stage sleep, and I always describe that as when I was in medical school, suddenly I'd hear my pen hit the floor, and I'd go like that. I wasn't sleeping, and light sleep usually starts, and light sleep is nice, but it's not really restorative. Then we go into deep sleep. And that's really where we start to consolidate memories and where our body recovers. And so some drugs can sometimes affect that sleep architecture, and especially sometimes they can decrease deep stage sleep. That's the more restorative. There's no indication that SSRIs typically affect sleep architecture very much. So it's usually not a problem. That said, SSRIs can cause people to be more tired. It's usually one of the things I tell people at the beginning is, if people are going to quit SSRIs, there are three of the most common reasons, and we can talk more about them later, but they typically are some weight gain and sexual side effects. And then the third reason is sometimes they're just a little sedating for people. And so first of all, sometimes it's simply when they're a little sedating or they affect people's sleep, the first thing we sometimes try is, when are you taking it? Are you taking it at night? If so, can we try taking it in the morning? Because sometimes even just a shift like that actually affects people's sleep less. But I think, anything can affect sleep, and it's also sorting out, are you not sleeping because you're anxious, or are you not sleeping because of the medicine? And any SSRI can cause a little insomnia, and any SSRI can also make you a little bit tired. And there are some that are more likely to do that than others. So I think, again, there's not real data that they disrupt sleep architecture, but they can affect sleep. And so if you're on a medicine that's causing you to have insomnia, and moving it earlier in the day still doesn't help, that there's a problem with sleep, then we might have to think about trying a different SSRI, because there are others that might not cause that same problem. And sleep is, I always tell people, sleep is the most underrated thing in the world. It's, the thing I always explain to people is, we always think about diet and exercise. And it's because with diet, there are a million different diets, and gluten-free and keto, and there's a lot to sell. And with exercise, there's spinning, and there's weightlifting and aerobics. With sleep, there's not a lot to sell. And so a lot of people take their exercise and nutrition really seriously, and then blow off sleep. And really getting a good night's sleep, I tell people all the time, if I wanted to make somebody anxious who wasn't, the first thing I would do is drop an hour or two off sleep each night, and they'll get anxious. And so I do think it's really important question for therapists and psychiatrists to always ask about sleep. And I always tell people, if an alarm clock is waking you up in the morning, you're not getting enough sleep, right? Because clearly your body was still sleeping and your alarm clock interrupted it. So that's always a good test to see, and again, a lot of people, think they can get by. And the last thing I should say maybe is, there are some people that used to be able to get by maybe on 6 or 7 hours of sleep. And when we start them on an SSRI, because it does make them a little tired, Now they can't get away with 6 or 7 hours of sleep. And so often, if they get a little bit more sleep, 8 or 9 hours, it takes care of that, but they just might not be able to get away with what they used to get away with.
Well said. I have a pre-submitted question. We actually had 2 on this. Can you talk a little bit about what SSRIs do, or is it mainly a placebo effect? So we got 2 pre-submitted questions asking, like, is there actual change that's happening in the brain, or is it placebo for the positive effects that people get with the medication?
So I think let's talk about placebo first. I think there's been a lot of things coming out of the news in the past 2 or 3 years about SSRIs, especially in depression. And how much data is there that SSRIs help a lot more than placebo. And it's a conversation that needs to be had. And I think the data still points to SSRIs being helpful. OCD is a different animal. OCD actually doesn't respond very well to placebo. And there are a lot of disorders that do. If somebody has panic disorder and you give them a placebo and say, this will calm you down, it works a lot. Just knowing that they're taking something to calm them down, it does that. OCD doesn't have a really big, we look at the research, it doesn't have a big placebo response. So we don't think that it's a placebo. Also, if it was more of a placebo, right, just scientifically, you'd assume that we get a placebo effect at normal doses, right? Because people don't know the difference, but we don't, right? We have to use higher doses for OCD. So I think that's one thing that kind of tells you it's not placebo. SSRIs are complicated. I think one of the problems is selective serotonin reuptake inhibitors, one of the things they do is increase serotonin. So the second people hear that, they go, well, that must mean I have low serotonin. Not the way it works exactly. One of the things I tell people is if, you didn't know anything and you landed on Earth and you didn't get enough sleep and you were tired the next day and somebody gave you coffee and it woke you up, well, it doesn't mean you didn't have enough caffeine in your system and that's why you were sleepy. You're sleepy because you didn't get enough sleep, and caffeine can help fix that. So just because an SSRI increases serotonin and that helps, doesn't mean that serotonin was the problem. What we do know is when we look at MRIs or PET scans, what we see in people with OCD is a couple of classic things. We see a couple of areas that are hyperactive. In OCD, those areas typically are the orbital frontal cortex and the anterior cingulate cortex. And then they attach to an area called the striatum, and an area in the striatum called the caudate nucleus tends to be hyperactive in people with OCD. And one of the things we know that's really interesting is when people get better, when their OCD gets better and we re-image them, those areas that were hyperactive slow down. That's the case when medicine works, but it's also the case when therapy works. And so we know, and I think that's maybe an important thing to say here. I think some people think, well, if it's a brain disorder, that it's somehow a biological disorder, therefore I need medicine. And that's not true, right? Millions of things affect the brain, like learning. So when people are doing therapy, one of my friends and colleagues and mentors, Dr. Tatsi Moritz, used to tell people a lot and say, we're doing brain surgery without cutting you open, right? Because we are. When we do therapy on people, it affects the brain. And those areas get affected. Medicine can affect those too. So one of the things we do know is that when we give people high-dose SSRIs and they work, we actually do see biological changes. And you do see on PET scans and MRI and on certain types of scans that the areas that were hyperactive kind of go down. But again, those tend to also go down anytime we have an effective treatment, including exposure and response prevention.
Well said. I'm going to read one more pre-submitted and then Liz is going to jump back to live. So we got a couple questions. So I'm going to mesh it into one. People had a couple questions about medications outside of SSRIs. So for example, a question about SNRIs, like is that an option if SSRIs isn't working? How about use adjunctive medications such as Abilify? And then lastly, are benzodiazepines helpful in OCD therapy or not?
Great questions. Let's see if I can remember them all.
So like SNRIs, adjunct kind of Abilifies, and then benzodiazepines.
So SNRIs stands for serotonin. So SSRIs, again, are selective serotonin reuptake inhibitors. And so they affect kind of the cell reuptaking serotonin. SNRIs affect both serotonin and a chemical called norepinephrine. Norepinephrine is also for people called noradrenaline. and people are more familiar with adrenaline. And so, there are a lot of different SNRIs. Some do mostly serotonin and a little norepinephrine. Example of that is a drug like Effexor. Effexor is almost an SSRI with some norepinephrine effects at higher doses. We've seen that Effexor looks like it works pretty well for OCD. The other SNRIs have less of an effect on serotonin and a little more effect on norepinephrine. And those drugs are things like duloxetine, which is called Cymbalta, and a drug called venlafaxine, which is Pristiq. And those SNRIs, the data is not so great. There are probably some people that respond to those, but again, it looks like the mechanism, even when those work, is the serotonin reuptake inhibition. So we usually, again, when we try people on SSRIs, usually we'll try one SSRI. If that doesn't work, we'll try another. Sometimes, eventually, we might try Effexor, but usually Cymbalta and Pristiq are not drugs we use. There are other much better options, even when SSRIs don't work. So that's kind of the SNRI question. The Abilify question. So Abilify is part of a group of drugs called atypical neuroleptics or atypical antipsychotics. Some people get very nervous because their doctor will put them on one and they'll Google it and they'll say, does my doctor think I have psychosis? They put me on an antipsychotic. They're used, often drugs get a common name based on what they're used for first. So in the same way that often SSRIs, even though we use them for depression, anxiety, OCD, sometimes people call them antidepressants because they work as antidepressants, but they do other things too. In the same case, neuroleptics, which are antipsychotics, were originally used for psychosis. But at lower doses, we do use them for things like augmentation in OCD and depression. And so if you look at the data, when people don't respond to an SSRI, if you add an atypical antipsychotic at a low dose, which Abilify is one of, about 1/3 of those people that didn't respond to an SSRI alone, 1/3 of them will respond. The most common people to respond when you add an antipsychotic are people that especially have OCD and also have tic disorders. That kind of subgroup, even more than 30% tend to respond. So the problems are, though, with atypical antipsychotics, there are a couple of issues. One is what's called metabolic syndrome, and that includes weight gain, insulin resistance, which is for people, it's like prediabetes, and an increase in cholesterol. And so those can happen. And sometimes people, psychiatrists, they think when they give low doses, they don't worry about those things, but they're still a concern. And so anytime you give somebody one of those drugs, you have to take certain measurements of cholesterol and blood sugar and weight. And so those drugs like Abilify can work. And again, about 1/3 of people that don't respond to SSRIs alone, but it's also weighing kind of cost benefit because there are concerns. And so, but they are drugs. And just, so we know the other drugs, in that class are Abilify, which is aripiprazole, risperidone, which is called Risperdal, Seroquel, which is quetiapine. And those three are probably the most common used in OCD augmentation. The last question was, I think, about benzodiazepines. And for people, the benzodiazepines include drugs like Klonopin, Ativan, Xanax, and Valium. And benzodiazepines have been used for years. And one of the main things they can do is decrease anxiety. And so while benzodiazepines don't have any effect on the obsessions and compulsions of OCD, for any disorder, they can sometimes bring down anxiety. Here's where the problems come up, and you guys will know this very well, is if I am going to use, I try to avoid benzodiazepines, but if I do use them, I don't like to use them as they're often used, which is on an as-needed basis. Right? So there are some people, they have a Klonopin in their pocket or an Ativan or a Valium. And when they get anxious, really anxious, they take one. But as we know, right, it's the exact opposite thing we're trying to teach people in therapy, right? We're trying to kind of teach people that when something makes you anxious, right, our job is anxiety tolerance, right, to go towards that thing, right? And so we don't like them to do anything that's going to skyrocket their anxiety down, whether that's a compulsion or, taking a benzodiazepine. It just kind of becomes a safety behavior. And you might as well be doing a compulsion. So I usually don't use them like that. Sometimes if people have very high anxiety, I might use something like, let's say, a benzodiazepine like Klonopin, where I give a low dose twice a day at regular intervals, which is usually twice a day, to just lower general anxiety. There are drugs we try to avoid. They can be addictive. There are certain issues with them. But I really do try to avoid the way a lot of people use them. I don't like the idea of people popping them as needed for high anxiety, just because it really goes against what we're trying to teach them in therapy. It really is whether we call it an avoidance behavior, a safety behavior. And so again, it's not just, should you use benzos, but how you use them. But again, in general, they don't have a real effect on the OCD primary symptoms themselves. They can lower anxiety for some people.
Yeah, and again, you guys remember, right, one of the things that we're talking about is how do we change our relationship with anxiety and OCD? We're trying to help us, right? We're focusing a lot on anxiety sensitivity and the way we respond to thinking anxiety is dangerous, and how all of that does is reinforce OCD. If we're feeling anxious, then we need to do a ritual. If we're feeling anxious, then we need to take a benzo, right? That can give that same message that anxiety is dangerous, that we need to be responding, right? And as Dr. Pascar is talking about, we're trying to shift that whole narrative. We're trying to help you learn and you teach your brain, right? As Dr. Moritz said, doing that like brain surgery without surgery. We're trying to help you rework and reteach yourself, your brain, your confidence, that we don't need something to feel better. And that, and so we don't want you to be relying on an as needed med if we can help it from a treatment perspective to reduce anxiety, just like we wouldn't want you to rely on a ritual. Do you agree?
Yeah, and I think one thing may be important to say, because I'm sure you guys get this question a lot as well, is, sometimes people say, well, isn't anxiety dangerous? Like, if I'm anxious all the time, doesn't that lead to people having heart attacks and all these different things? And they're not wrong, right? Being chronically, constantly anxious isn't good for you. But in order to not be chronically anxious in the long term, in the short term in therapy, we actually do have to do things that make you more anxious. And there is no problem with short-term, even very high states of anxiety, right? And part of why we're doing this therapy, and often what we tell people is, we're going to increase your anxiety now in the short term, so in the long term, it's not as much of a problem for you. And I think, also kind of teaching, a little bit, I think there is some confusion. I think even as I'm sure you guys know, in the therapy world, with people that don't do a lot of this, they kind of still teach what's called kind of a habituation model, that in some ways anxiety is kind of supposed to go down.
Yeah.
Right? And that really is not how it appears to work, right? It's really more and more we're realizing this is an anxiety tolerance model. Right, and we're getting more used to kind of anxiety. The example I give people is, if you jump in a cold pool of water and you stay in there for a while, eventually the water, it feels warmer, right? But the water hasn't changed temperature, right? You've changed, right? And so if you look at anxiety as the water, right, anxiety doesn't need to change. The more you spend time with anxiety, you change. And so, even though the anxiety technically might not be changing, your response to it changes. You build up a tolerance to it. And I think, again, for a lot of people that don't do a lot of this work, they kind of still sometimes teach a different model. And I think it's hard because sometimes patients sit there and they go, is my anxiety down? Is my anxiety supposed to be going down? And, as you guys know, the more you try to get anxiety to go down, the more it goes up. So, it is teaching an anxiety tolerance model. And again, like we said, taking a pill to get that to drop down just tells you, well, why would I be taking a pill for this unless anxiety was dangerous or bad for me? As opposed to what we really tell people, which is anxiety is an alarm that was invented to warn you about danger. The problem is, just like any alarm, sometimes people's alarms go off when they're not supposed to. And really that your anxiety is going off when really it's not needed. There really is no danger.
That's right. That is right. So next question that is at 12:15 your time, Amanda. Can you address extreme tiredness? And I know I just want to hop in. I know there's lots of questions. We'll do what we can to get to all of them, try to speed through these. So can you address extreme tiredness and fluvoxamine? My son sleeps over 10 hours a day regularly and frequently even longer.
So yeah, a couple of things. One is, just to answer, because I think people are asking about specific medicine. And it's interesting, right? That one of the things I said before was that there's not really a lot of data to support one SSRI working any better than any other. So then the question becomes, well, then how do you choose one? And often we choose one not because one benefits more, but because different SSRIs have different side effects. And so, if I have somebody that gets tired very easily, I usually don't use a drug like fluvoxamine, which is also called Luvox, because it tends to make people a little bit more tired. Now, on the other hand, if I have somebody with OCD who gets anxious and can't fall asleep at night, fluvoxamine is a great drug because it'll make them a little bit more tired. So typically, if somebody is having, and again, I think we talked earlier, again, the three most common reasons people will go off SSRIs or have problems, one of them is it can make people really tired. And so if somebody was sleeping 10 hours a day, first, I just want to make sure that their sleep behaviors are good, right? Their sleep hygiene is good, and they're doing all the regular things to normalize sleep. If it was still a problem, then it would depend, right? So if Luvox was working unbelievably well, and maybe they tried, so let's say somebody tried Prozac, didn't work, tried Zoloft, it didn't work, and they're on fluvoxamine, it's the only thing that works for their OCD, and it's great, and they're sleeping 10 hours a day, then we might try to give them a medicine that actually can help them with the tiredness. If it's the first medicine they tried and it works, or it doesn't work any great shakes, then I might want to try them on another SSRI, especially one that doesn't tend to cause as much tiredness. So again, it often depends where kind of to make those decisions. Is it's not as easy as just kind of seeing this kind of like cross section of, okay, this person's on fluvoxamine and they're sleeping a lot. Was this the first drug tried, right? Again, the willingness to tolerate certain side effects depends on what you get benefit from. So again, I'd have to, again, like we said, you have to know a lot more about this case to know, what you would do. But any SSRI can cause tiredness, but I would say that on the spectrum of that, fluvoxamine is one of them that tends to cause that more commonly, and therefore there is a good possibility that maybe on a different SSRI they wouldn't get that. But I'd also be curious when they were taking it, and seeing, sometimes changing even the time of day can help a little bit.
Yeah, and some of the questions you guys that you're posting are specific questions for your own doses and things like that. So I may be skipping some of that because I think it's really important for us to get some broad perspective on medications as a whole. So the next question I'm going to hop to is at 12:28. How about integration of, I don't know how to say this, so you'll have to say it, but anxiolytic.
Where am I looking?
And anxiolytic. See, such as gabapentin with an SSRI. Is this a good integration, or is that just to help with the residual anxiety that an SSRI may not help with?
Okay, so anxiolytic, right? So it's a fancy word. All that means, right? Anxiety is angio. Lytic just as lysis, breaking. So an anxiolytic is any drug that decreases anxiety. And so benzodiazepines, like we talked about before, are anxiolytics. Gabapentin is a particular medicine. Gabapentin does a few things. It affects kind of what are called GABA receptors. And when you hit GABA receptors, one of the things you can do is decrease anxiety. Gabapentin is also commonly used. Basically anything that hits GABA decreases brain activity. So gabapentin is used for anxiety because it can decrease brain activity in the amygdala, where we get fear. Gabapentin is used for pain because when there are hyperactive receptors, we want to calm them down. Gabapentin does that. Gabapentin is commonly used for sleep, right? Because again, it just calms the brain down. So gabapentin doesn't have any particular benefit as far as, again, the main symptoms of OCD, which are really obsessions and compulsions. it can sometimes help with kind of excess anxiety. And again, I kind of talk about it the same way I talked about the benzodiazepines. I don't like to use gabapentin on an as needed basis for when people get really anxious to pop one, because again, it gets into a really bad mindset that's very against what we're doing. But for some people, I will give them gabapentin, which often to work all day has to be given 3 times a day. So sometimes when people have just a lot of residual anxiety, we'll use it. Although again, SSRIs tend to be much more strong at breaking just anxiety as well. And so gabapentin is usually a lighter drug, but for some people it works. And again, I tend to use it a lot sometimes when people have some SSRI-induced insomnia. And sometimes giving them gabapentin at night kind of calms their and helps them sleep a little bit better.
One question that we got pre-submitted is if somebody is experiencing heightened anxiety or heightened symptoms or, different just dysregulation when starting a medication, how long should they give that a chance before they abandon the medication and try a different medication? So if they're starting to see some of those symptoms right away.
So that's it's a very dysregulation is kind of a broad term, right? Of a bunch of bad things that could be going on. And so it really depends on what you're seeing. And again, one of the things that I think is easy for some, psychiatrists to say is, just write it out, like just give it more time. And that's easy to say, but you're not the one that's suffering. So, sometimes, so there are cases, for example, where with some people, when you give them an SSRI, it can actually cause an initial rise in anxiety. This is most common in people that also have panic disorder. That sometimes an SSRI will give them initial anxiety. The way I tend to deal with that is I tend to start the dose very low. And I find that when you start it low and go up slowly, you're less likely to kind of get that type of anxiety. If you do, it's about what the level is. And so if it's mild anxiety increase, we really try to get them to stay with it because over time, the SSRI will start to help that. There are people where their anxiety is so high, and then when we give them an SSRI, it even hikes up more, that sometimes we use the drugs we talked about before, benzodiazepines, as what we call a bridge, right? That we might give somebody, as I'm increasing their SSRI, a low dose of Klonopin twice a day to kind of keep their overall anxiety a little bit lower. And then as the SSRI starts to take effect, I start to slowly get rid of the benzodiazepine. But I try to avoid it when I can. And for most people, if you start low and go slow enough, you can get them through that without too much of an anxiety increase. And most people don't have that anxiety increase. Again, it's most common in people that also have panic disorder. And again, one of the things we always talk about is most side effects that one will get with any medication are usually, it's kind of the opposite of how treatment effects work, right? With a treatment effect, at the beginning, you don't really see anything often. And then after a while, you start to improve. It's kind of the reverse with side effects, right? Often you'll get some side effects early on, and then as the body adjusts to it, they go away. So, but sometimes they don't. So, some of the early side effects that people will get is an anxiety increase. Sometimes there might be a little sleep dysregulation that improves over time, so you want to follow it. And again, how bad it is lets you know, do I need to jump in with another medicine? And again, that's got to be on a case-by-case basis that you're really trying to figure that out. Probably the most common thing people get when they start an SSRI is they can get a little bit of nausea. And part of that's just because you have serotonin type 3 receptors that kind of line your gut and your belly. And so when you start an SSRI, sometimes those get activated and people can feel queasy and a little nausea. It usually goes away pretty quickly. It's not something that tends to last. If you start medicines again slow enough, so just maybe I should have said this earlier, when I start SSRIs, there's a starting effective dose which is the starting effective dose for things like depression. I usually start at half of that dose for 5 days and then go up because that usually helps me get around some of those early side effects. Like some, again, stomach upset, increase in anxiety and things like that. But again, most side effects that people get with SSRIs, a lot of them go away with time. And so again, it's just depending on how severe they are and what the patient can tolerate. And it's that conversation about, hey, Can we just keep going, or do we need to kind of jump in? And again, it's a case-by-case basis.
Well said. We have a question at 12:49 from Dave Raven. Is there genetic testing right now that can indicate whether specific medications would be effective for an individual?
I'm going to say this very loudly because it's a question I get too often. No, there is genetic testing. It has no good data that it really does much of anything at this point. And if you look at it, if you look at all of the studies, we've done plenty of studies where we have a bunch of psychiatrists that don't use the testing and a bunch that do, and they don't get any better outcomes. And I think this is one of those things that I do think in the future, when we get it better, will be helpful. Right now, I think it often causes more problems than it solves. And there's a couple of problems with the genetic testing that we use now. One is, most of these tests measure enzyme activity. And so they'll look and they'll say Prozac is, affected by this enzyme, and this enzyme in the person is very slow, so they'll get too high of a level of Prozac. What they don't realize is other enzymes, when that happens, often pick up the slack. Enzymes don't work in isolation. So when you're looking at these tests and they tell you this enzyme is this or this enzyme is that, and this will do X, Y, or Z, it's assuming almost that enzymes work in isolation, and they don't. They work as a team. And so right now, I think it's a waste of people's money, to be honest with you. And I don't see much benefit. That's not to say that we won't get it better in the future. And my guess is, 5-10 years from now, it'll be something that's more worthwhile. But right now, it still hasn't, really shown impressive evidence to really change anything, unfortunately.
I appreciate the candid response, and I like it when we're direct and clear because people need to hear that. There's a couple more questions, so I want to try to lump them into two. One of them is, if I move up on Prozac, if I were to move up on Prozac, would it make me more tired? I really feel like I need it, but I'm already feeling tired. I'm also depressed. Should I ask for a medication to take alongside Prozac, or is it better to just increase the Prozac? They were surprised because they were on 80 milligrams and they thought that was the highest they could go.
So with side effects, one thing maybe to tell people is, I look at side effects sometimes two different types. There are side effects that just seem to happen when you give somebody a drug, and it doesn't really matter the dosage. So for example, weight gain. Some people can get a small amount of weight gain with SSRIs. It doesn't usually appear to be dosage related. So if you're going to get it at a low dose and you get a little weight gain, it doesn't mean you're going to get more at a higher dose. It just doesn't seem to be dose related. Other things can be dose related. Kind of tiredness can be, and sexual side effects can be. And so they can sometimes get worse at higher doses. But at the same time, I would say, in the same way that some people's OCD will get better at higher doses, some people's OCD stops getting better after a certain dose. So you don't really know for sure, right? Just because you're getting some tiredness at 80, it doesn't mean you will get more tiredness at 100. It's possible. And so typically, I think you do a trial. And a lot of times, again, there aren't really answers to these questions. And the only way to get answers is sometimes by trying something. So I think, you can try increasing it, and you might find that there is no difference in tiredness. Where you might find there is. And so, you only know that by doing it. I don't like people to just assume because you can get a side effect that you will get a side effect. Because those are two different things. I think the other question was about kind of depression. So SSRIs are also, right, the standard kind of treatment for depression, for a major depressive disorder. And so some of the question would be is, when people use the word depression, sometimes we use it like in our common vernacular to mean sad, right? And there's a difference between depression, major depressive disorder, which has a group of symptoms, and being sad. So first I have to figure out, is this a major depressive disorder? If it's not being helped by the SSRI, sometimes a higher dose would help. Although with SSRIs, you don't usually need higher doses. So I'd have to know more about the case, and then you make a decision. Do you add something, right? Sometimes you might add a different drug. A common drug we add when an SSRI alone isn't doing everything we need for depression is a drug called bupropion or Wellbutrin. And the reason for that is kind of SSRIs affect serotonin. Wellbutrin affects dopamine and norepinephrine. And sometimes increasing those can also help depression. But again, you got to really, again, these are tough questions to kind of answer because you really have to know the case, what's been tried, what's the nature of the depression. So, hard to really give an answer here.
Well, it is 12 noon, 1 o'clock Eastern time. Chris, I never know what time it is your time, 10 a.m. So thank you so much for joining. It's clear that we need to have another talk on medication. There were lots of questions that we didn't get to. This live stream will absolutely be available on YouTube afterwards. You can go to IOCDF's YouTube channel and you'll be able to find it there. Dr. Pascar, thank you so much for joining us. We hope that you'll come back because there's lots of questions to be continued, and I think a part 2 is definitely needed.
I would love to.
Thank you. So I'll wrap up and we'll let Chris say a few words and then we will end with you. Just thank you all for joining, and I am hopeful that today you were able to get some really good information and education on the role that medication plays in the OCD treatment cycle. One thing that I took away is that there's incredible medication and that it is a frontline treatment for OCD. And I also took away a reminder for all of us that so is ERP, so is behavioral therapy, and that they need to happen together, not in isolation. Chris?
Yeah, no, thank you so much for being here. I mean, we get so many medication questions. We still have a bunch pre-submitted. So yes, please come back. We'd love a part 2. But I'm going to echo what was just said and what you said, Dr. Pascar, earlier. But what Liz just said is that it's a team, and finding somebody who understands medication from an OCD lens is important, and then having them communicate with your therapist so you can really do the ERP, the behavioral work, and make that unison get better. So please absolutely think of it like that. I wanted to make a quick shout out. We have 2 upcoming conferences coming up. So I put the link for Amanda to throw up, but we have the online OCD camp the weekend of February 4th and the online hoarding disorder conference the weekend of March 4th. So make sure you're heading out to that.
Dr. Pascar, we'll end with you. Any final thoughts, questions, or comments?
I think what Chris just said is really important. I guess we didn't mention that. One of the biggest problems is psychiatrists not speaking with therapists, and it's a team. And the therapist often is going to see the patient a lot more frequently than you are. And it's good to get objective data, not just from the patient's report, but also from the therapist's report. And I think a lot of psychiatrists need to do a better job making sure that they are in regular communication with the therapist. To not do it just doesn't make any sense. It doesn't serve the patient. It really is a team, and you have to, if you're going to do OCD work, you have to be willing to work in a team because it really is important.
One thing Jeff Szymanski taught me when we were talking before about PANDAS is the biggest red flag is if people aren't willing to work together, right? And I think that's the case across OCD work. And so what I will say is I actually hear a lot of clinicians sometimes say, well, I'm scared to call the MD, or I'm scared to call the psychiatrist and tell them what to do. I don't want them to think I'm telling them what to do or stepping on toes. And really, this should be collaborative, and we shouldn't be splitting with the patient, or we shouldn't be stepping on each other's toes. We should be working together because at the end of the day, all of our goals should be to move the patient forward in their treatment.
And any psychiatrist that's not willing to answer a therapist's questions or you as a patient's questions, go see somebody else. That's part of their job, is to answer and make you comfortable. And if they're not doing that, you should probably find somebody else that will.
Bingo. Love that. Perfect way to end. Thank y'all so much for today. We'll see everybody soon.
All right, take care, everyone.